Good evening, everyone. Welcome to another lively session of 4D 3.0, detailed discussion and dialogue in Indian diabetes, where the nephrologists, cardiologists, and endocrinologists meet not to compete but to collaborate. I am Dr. Saurabh Sharma, Associate Professor at VMMC Safdarjung Hospital, New Delhi. So, our theme tonight is When Sodium Falls, Managing Hyponatremia in Heart Failure and Diabetes. So it is one of the things that can turn a calm ward into a crisis. And whether it is an ICU, dialysis unit, or endocrine clinic, sodium loves to keep us on our toes. And who better to discuss with than with the three of the Mumbai's best minds? Dr. Meet K. Kothari sir. Sir is interventional cardiologist, Horizon and Upasani Hospital, Mumbai. Dr. Manjiri Pramod Karlekar ma'am. Ma'am is consultant endocrinologist at Jain Hospital, Chembur, and Dr. Divya Vajpayee ma'am, consultant nephrologist at Fortis Hospital, Mulund, and honorary professor at KEM Hospital, Mumbai. Welcome, sir and ma'am.
Hello.
So,
Thank you.
all the three of our panelists are from the city that never sleeps, Mumbai. So maybe that's why they can handle the late night sodium drops better than anyone else. So before we start, a quick question with all of you, sir and ma'am. So what is the one thing about Mumbai that keeps your sodium levels stable after a long and stressful day? A vada pav, a sea breeze, or something else? So first, I would like to ask Kothari sir.
Definitely, it is vada pav. If you all like vada pav, it is definitely the vada pav that keeps up the sodium. So things apart. So usually, why this sodium levels matter in our cardiology or any case of heart failure is because frequently what we get is heart failures with reduced ejection fractions or preserved ejection fractions, wherein two mechanisms usually happen. One of them is a neurohormonal dysregulations and also the volume overloaded states. Diabetes prevalence is really high currently, and in nowadays the hyperglycemic related translocated hyponatremias are also very common.
Yes.
These are all related to diuretics and poor intakes, comorbidities, and they come under an entity called as osmotic hyponatremia, that is a true hypotonic hyponatremia. So cardiologists must rapidly distinguish themselves with the urgencies related to this sodium levels, and also the best strategy related to the cardiometabolic mechanisms should be there. We don't need to overtreat, don't need to undertreat the sodium, and it's a scary thing definitely, but we will have to be very vigilant with treating sodiums related in heart failures.
Thank you very much, sir. So, as Kothari sir has mentioned, it is vada pav that keeps his sodium levels stable after a long, stressful day. So, the same question is with Manjiri ma'am. Ma'am, what keeps your sodium levels stable after a long, stressful day?
I think it's not just the vada pav, but Mumbai is famous for many other salty snacks, and it can be your pani puri or any kind of chaat, or of course, vada pav is the staple in Mumbai. But yeah, keeping jokes apart, I think it is the normal homeostasis which is maintained, the fine
Yes.
link between these three systems, that is the endocrine, the renal, and the cardiac system, which maintains the normal sodium levels in a normal individual. So yes, patients who are euthyroid and normocortisolemic and do not have any acute conditions should have a normal sodium level even at the end of a stressful day.
Thank you, ma'am. So, the
Yeah.
same question with Divya ma'am also.
Yeah, Saurabh. So I would say, I being a nephrologist, I'm against all salty food. I won't
Yes.
let
Okay, ma'am.
anyone even talk about vada pav and pani puri here. And I would say, especially this year, we have had uh, huge amounts of Mumbai rains. So lots of
Yes,
rains. It
yes.
has rained almost for maybe 6 months in Mumbai, and that is adding on to the hyponatremia part, because today we are discussing the falls in the sodium. So maybe the fluid, all the rains. This is what I could think of, because lots of my patients, those with decreased GFR, kidney problems, have hyponatremia because of they are having lots of fluid. And also, when I share patients with Dr. Kothari and Dr. Karlekar, especially Dr. Kothari, because they have fluid because of the heart failure also. So
Yeah.
that leads to fall in sodium. And the problem with sodium is that it is the most common electrolyte abnormality, as you would know. Like if the patient has electrolyte abnormality, if you have to put your beds on one thing, it's sodium. That is the most common
Yes.
electrolyte abnormality worldwide, both IPD, OPD, and it is uniformly associated with poor outcomes. So hyponatremia in heart failure, hyponatremia in CKD, hyponatremia anywhere, and even hyponatremia for that matter is uniformly associated with increased mortality and morbidity. So I'm so glad to be discussing that with all of you today.
Right.
Thank you very much, ma'am. So, Divya ma'am has related the sodium with the hypervolemic hyponatremia in her patients of heart failure as well as diabetic kidney disease. So they are overfilled with water, and she has related it with the rainy season in the Mumbai and the humidity in the Mumbai. So coming to the basics, like why and how the sodium falls. So let's start with some fundamental question. So sodium doesn't just fall; it means something like we have to find out what's the cause. So in your respective fields, what does the low sodium really tells you? So Kothari sir, question is in heart failure, we often see hyponatremia as the rule, not as an exception. So do you
That's it.
see it mainly as a marker of disease severity or an active contributor to poor outcomes?
So definitely, I must say that neurohormonal activation is directly related to the cardiovascular risk. Okay, and in patients with heart failure with reduced ejection fractions or reserved ejection fractions, when the sodium levels have decreased, it's definitely the hypervolemic hyponatremia that comes into the picture. So the main investigation and to treat the cause, basically why we are treating the sodium is because the sodiums have come low, and we just don't treat the numbers, we treat the symptoms. So how urgent is it to treat the symptoms, and whether the neurological deficits are present decides whether the urgency is there in treating the sodium levels. So immediately what we go through is, after seeing a sodium, we have to check one of the parameters with plasma osmolality, and the volume overloaded states definitely decide whether these things need to be managed with an balance of sodium levels. And that's it. So treatment depends on the cause. Definitely, if it's a diabetic patient with an hyperosmolar hyponatremia, definitely then we have to treat it with the insulin, and there comes the role of these insulins and fluid managements, which need to be balanced. But overall, I think diuretics with a restriction of fluid at least 1 liters for all cardiac patients in an initial stage is a must. And repeating sodiums has to play an important role. And that's it.
Thank you, sir. So that makes sense because low sodium often means high neurohormonal activation. So it's
Exactly.
message from heart that it's struggling. So as
Yes.
you said, it's both a signal and a symptom. So the second question comes to Manjuri ma'am. Manjari ma'am. So ma'am, in diabetes, we often see hyponatremia that's not real. It's
Yes,
translocational. So how
yes,
do you
yes.
quickly differentiate a true so how do you quickly differentiate a true hypotonic hyponatremia from glucose-related pseudo-hyponatremia?
So you can actually, apply the sodium corrections which are there and see whether it is the true hyponatremia or pseudo hyponatremia because of translocation. So not just the glucose, but many other, hyperosmolar states can have pseudo hyponatremia. So applying this the corrections can help you in deciding whether it is the true hyponatremia or pseudo hyponatremia. So that is one way in which you can, differentiate between these conditions. Yeah.
Yes, ma'am. So, as you have mentioned, it's a
Yeah.
great practical point to correct
Yeah.
sodium for glucose before panicking
Yes.
for hyponatremia.
Yes. Yes.
Yes, ma'am.
Yes.
S- So, the next question is for Divya, ma'am. So, ma'am, from the nephrology lens, when you first see a patient with a sodium of 122 milligram per deciliter, so what are the top two questions you ask yourself before touching the fluids?
Yeah, very important. So, the first thing I want to know about the patient is what is his or her volume status. Whether the patient is euvolemic, hypovolemic, or hypervolemic, because my complete treatment and even the investigations which I'll be ordering depends on that condition, on the volume status of the patient. So like, because right now we are focusing on diabetes and heart failure, so our main focus is on hypervolemic hyponatremia. Those patients, what actually happens is that effective circulatory volume goes down, so the body feels that there is no volume. Even though body is filled with water, it feels that there is no volume. So because of that, body activates three things which it usually does. First is RAS, second is epinephrine, norepinephrine, and third is ADH. So all those hormones go up, and what they do is to bring lots and lots of fluid inside to maintain the effective circulatory volume, and that dilutes the sodium and brings the sodium level down. So that is, in very very short, hypervolemic hyponatremia. Vis-a-vis someone who's hypovolemic, for example, they are having losses, they can be renal, but like if I give lots of diuretics, I give indapamide, I give thiazide, metolazone, something like that. All the water and sodium, everything is lost in urine. Or like in rainy season, we have lots of tropical illness. So not very uncommonly, we have these patients who come with diarrhea or diarrhea-related illnesses, acute febrile or tropical illnesses. They lose sodium from gut. Along with some water, they lose it from the gut, so they become hypovolemic hyponatremia. And the third is euvolemic hyponatremia, which can be because of SIAD related to various drugs and all. So that is the absolute first question which I want to know: what is the volume status of my patient? And the second question, very important, I want to know is that what is the duration of this hyponatremia? Whether it is acute, whether it has happened within 1 or 2 days. Maybe we can take a cutoff of 48 hours here, that is 2 days, or whether it is chronic. Because if it is acute, I am not very worried about treating it a little fast. I would like to make it normal as early as possible. However, if it is chronic, I would like to go very very slow, because it can I can cause more problems than good in terms of brain demyelination if I treat it fast. So those are my top two questions: volume status and acuity of the symptoms.
Brilliant, ma'am. So volume status and duration, these are the two pillars, and they can instantly tell us if the sodium fell fast or slow, and whether the correction will heal or harm. So brilliant, ma'am. So this was a discussion about the foundation. So sodium can fall from heart overload, hormonal imbalance, or renal mismanagement. So now let's see what happens when we actually try to fix it. So coming to the correction conundrum. So once we identify hyponatremia, the next challenge is how fast and how much to correct. So, and that is where opinions differ as much as the Bollywood movie ratings in Mumbai. So coming to the first question with Kothari sir. Sir, the heart failure patients are often on loop diuretics, on SGLT2 inhibitors, RAS blockers, and all can worsen sodium levels. So, how do you strike the right balance between these life-saving drugs and maintaining the safe sodium level?
So basically, the GDMT, that is the guideline directed medical therapy for all heart failure patients, is definitely one of the drug pillars that we try to improvise to increase the effective arterial volumes of the blood. So they definitely reduce the ADH levels, and the A's, the ARBs are one of the pillars. Then beta blockers are the other, the MRAs, the SGLT2 inhibitors are the third ones. We have severe symptomatic hyponatremias if the patient presents with a really high levels of neurological deficits like seizures or coma. Definitely the treatment should be with a hypertonic saline 3% bolus, which is guided by the neurologist under strict monitoring. But a worsening of hyponatremia or a moderate type of hyponatremia which is non-life threatening, fluid restriction will be my first choice, and then around 1 liter and below of fluid restrictions in the 24 hours time interval in the ICU with loop diuretics to just mobilize the free water. And these loop diuretics definitely reduce the medullary gradients across. and if they are refractive to these therapies in the heart failure point of view, then what we have an option of adding the tolvaptans, which we all know that increases the free water excretions, and they try to correct the heart failures, but in the longer term they are not beneficial per se. Through the two trials that we all know, that one of them was an Everest trial, which involved 4,000 patients, and the other was a SALT trial. And the long term benefits for these tolvaptans have not shown great effects, but yeah, definitely the symptoms and the numerical values in the sodium terms have increased dramatically in refractive hyponatremias. We try to avoid over aggressive hypernatremia therapies unless there are very severe neurological compromises. Aggressive corrections in chronic also lead to these osmotic ponds and osmotic demyelinations. So, coming to the translocation hyponatremias, these are again, as Madam told, that true corrected sodiums need to be calculated, and based on that, the insulins and the fluids are to be given.
So, as you rightly mentioned, sir, watching the volume and adjusting the dose, adding loop diuretics, and continuing the cardiorenal protection. So, that is the major pragmatic point. Coming to the next question with Manjari ma'am. So, ma'am, in SIAD and other endocrine-related hyponatremia, we often restrict the fluids. But in Mumbai's summer heat and humidity, that is easier said than done. So, how do you ensure compliance and patient safety with fluid restriction?
Yeah, so that is a very good question. Actually, see, if it's a chronic hyponatremia, then a lot of fluid restriction may not also help in correcting the, sodium. Also depends on how low the sodium has gone and whether fluid restriction is going to be beneficial or not. That is also something which needs to be considered. And these elderly patient of ours, they are chronically hyponatremic. So any acute related illness also in them can precipitate them into going into severe hyponatremia. So in these patients, it is very important that you don't correct it very very fast. Otherwise, you can, if it's an acute hyponatremia, you can fast correct these hyponatremias very fast. But otherwise, you should go slow on them. And of course, you should always check for the drugs like thiazides are one of the most common drugs which we see in our day-to-day practice, especially in elderly people who are prescribed thiazides and they suddenly come into the ICU with a seizure, etc. So these things are to be kept in mind when you are evaluating patients with hyponatremia. Of course, your question is very valid that, how do you restrict fluids in them? So you should actually tell them that, whatever see if it is the rains, I mean if it's summers, you can be little bit lax on your fluid restriction because they have insensible losses, etc., which are happening. So you can allow them a little more fluids to be taken. And of course, if it's a chronic hyponatremia, then you can give a small dose of tolvaptan, which will keep their so if the patient is on tolvaptan, then they need not be fluid restricted, and then you can allow them to have more water uh, and other fluids if they are on tolvaptan. So that is one thing which can be considered. Of course, you should be careful that you're not increasing the sodium very very fast. So if it is severe hyponatremia, don't go for tolvaptan. Allow the sodium to reach a particular level, and then you can offer tolvaptan, which will not correct the sodium to a very great extent and suddenly do that.
So exactly, ma'am. So we need to be more judgmental and to counsel the patient, like you have mentioned, everything and explaining the why. So explaining the patient about the brain protection that this fluid restriction will
Yes.
deliver. So mostly they actually follow the advice. So then next question is for Divya, ma'am. So, ma'am, everyone knows about the dreaded complication of correcting hyponatremia, the osmotic demyelination syndrome. So, what is your golden rule or the bedside formula to ensure sodium correction is safe?
Yeah, so I am okay with. We are talking about chronic now, right? Because if it is acute,
Yes, yes,
we
ma'am.
can go a little faster. So chronic is the most common. Hardly people who are like marathon runners in Bombay, we have lots of them. So they come with acute hyponatremia, and there we need to really correct it fast to save their life. That's a life-threatening complication of very strenuous exercises. But apart from that, the garden variety, like what we were discussing, the most common electrolyte abnormality is hyponatremia. Majority of them maybe over 95% are chronic. So let's talk about chronic. Now your question is that what is my rule of thumb to save
Yes,
anyone
yes,
from
ma'am.
brain demyelination? So I would say I would not correct anything more than 4 to 6 MEQ, max 8 MEQ in 24 hours. See, the logic here, Saurabh, is that if my sodium is really low, for example, if it is, for example, let's say it is 105. I commonly see this 105 level. If I raise the sodium by 5, so I'll make it 110. Whatever acute danger was there to my patient, he was going to cone because of brain edema, or he was going to develop a seizure and die because of aspiration or whatever, is cured by raising this sodium by 4 to 6 MEQ. Beyond that, if I do anything acutely, I'll be doing more harm than good, because I have brought the sodium up, the brain edema has decreased, and the life threatening complication which was going to happen will now not happen. So immediately within 24 hours, I'll raise it by 4 to 6, max to 8. I prefer that in within the first 10-12 hours, I raise it by 4 to 6, and maybe 2-3 more by the end of 24 hours, and that keeps me safe. I don't want to normalize it to 130 in one day. So from 105 I'll go to 110, then the next day I'll go to 118, and then the next day maybe I can go to 122 or 123 or maybe 125 also. And this is like a sweet spot where I am not pushing my patient into brain damage, and I'm also avoiding the complications of persistent hyponatremia. So but this is very easily said than done. Like you asked about formula, so I use this, I calculate urinary electrolytes, and I use this formula of urine sodium plus potassium, urinary sodium plus urinary potassium divided by serum sodium. And if that is less than zero point 0.5, I am very much assured that the only thing I need to do is fluid restriction. That this level of urine electrolytes and serum electrolyte tells me that kidneys are still working and they're diluting, and only I need to fluid restrict. It is difficult, as Manjri said, but that will help, that will suffice. If it is more than zero point 0.5, then I will have to do something more than fluid restriction. Maybe give 3%, maybe give NS, maybe give Tolvat. If Dr. Meeth has a very overloaded patient, I would give loop diuretics along with his consultation. So that's how I go about it.
So perfectly said, ma'am. So we have to go slow, recheck often, and never chase the numbers. So so these were the excellent insights, and so far we have seen that correction of sodium needs personalization by the heart, by the hormones, and by the kidneys. So coming to the prevention and teamwork. So so uh, we will talk about the coordination and prevention and the real life pulse. So this question is for Kothari sir. So, sir, in your practice, do you use sodium trends as an early warning in heart failure follow-ups? And can a small drop predict impending decompensation?
Yeah, definitely. So first of all, I need to confirm the hyponatremia. So what I basically do is send the serum sodium levels and confirm it through a plasma osmolality levels too, whether the osmolalities are on a lower end. And definitely after that, it's all about the symptoms. If the patient is really in an acute heart failure, we have to treat it accordingly. Now, if he presents with an symptom which is neurologically deficit, we need to correct the neurological side immediately by giving 3% salines. But immediate threats are need to be treated. But as far as heart failures are concerned, it's a combined treatment with fluid restriction as well as loop diuretics, and also optimizing the GDMT pillars, which we use ideally for increasing the cardiac output and optimizing the cardiac functions, so that overall there is an effective volume of the blood which is increasing in a longer run. Definitely, Vaptens have helped in the refractive sodium cases as far as cardiology is concerned. And in all diabetic patients, it's all about sodium, correcting sodiums, not correcting too fast so that the sodiums don't rise very quickly. And that's the and avoiding all types of diuretics which are there, especially the thiazide diuretics, other drugs which are there. Anti-epileptic drugs like carbamazepines are commonly used. What we come across commonly is NSAIDs being used by many physicians, orthopedicians, especially just before their admissions in heart failures. And NSAIDs given, we all know that the prostaglandins which are excreted, definitely they get an impact. And that's why the patient presents with a failure sign, and prevention is definitely there. But overcorrection needs to be prevented. So 24 hours, again, as madam told us, urine sodiums, urine plasmolalities, osmolalities of urine help us in the longer run for all preventions in treatment.
That was insightful, sir. So I often tell my residents that that in these admitted patients of cardiorenal syndromes with hyponatremia, the serial sodiums are just like ECG of fluid balance.
Exactly.
So spotting early dips can actually prevent readmissions.
Yes.
So the next question is for Manjiri ma'am. So ma'am, many diabetic patients also have CKD, and that is a double-edged sword. So what's your quick checklist before declaring hyponatremia as endocrine rather than renal?
Yeah, so of course you have to check for the volume status. That is the first and the foremost, because if it is hypovolemic or hypervolemic, then it is definitely either CKD related or heart failure related. If it's euvolemic, whereas, so then that comes into the endocrine part of hyponatremia. So yes, you have to check the sugars, you have to check the creatinine levels, and check the volume status. So other parameters like your uric acid level, etc., can help you in deciding, what these causes are. But more or less, the volume status will help us in identifying what the cause, and of course, the creatinine levels and the bun levels, and yeah, these levels will help us in identifying whether it is hypervolemic or hypovolemic. And if it's not any of these, then you can consider it to be euvolemic and then further evaluate for the cause of euvolemic hyponatremia.
Nicely said, ma'am. So during it reminds me of my MD days also. So our unit head was Dr. S.K. Jain sir, who was a renowned endocrinologist. So he used to say in hyponatremia patient that never blame the glands before ruling out the kidneys. So exactly what you have mentioned. So coming to Divya ma'am. So ma'am, you are often the final call in multi-specialty hyponatremia cases. So what's one area where you wish that cardiologist and endocrinologist should refer a little earlier?
So I would say in a patient, I would say they should call us a little earlier before the sodium goes below maybe 120, or I get calls when it is majority of times when it is below 100. So I get calls when it is 94 or 96. So I would say, like you were talking about trends. So I'm sure lots of Dr. Kothari's patients with heart failure with reduced ejection fraction will have sodium around hovering around 124, 125, and he is okay with that. I would say don't treat that also if the patient is otherwise doing well, because we are not here to treat numbers. And it is proven in trials that normalizing sodium will not do anything to save for mortality. However, if the patient is having some gait abnormalities or imbalances or little slight dementia, some CNS problems, then only we treat them. However, once sodium starts dipping below 120, I would be very, very happy if my friends here would involve me earlier. And also in patients who are on various drugs, for example, I would like to say, not to Dr. Kothari and Karlekar, we have lots of onco patients nowadays, lots of new onco medicines coming.
SID.
Yeah, I'm seeing lots of patients with newer onco drugs causing SIAD. So, whenever a patient is on a therapy which is known to cause SIAD, and there is a slight trend of downward trend of sodium, in those patients at least we should be involved a little earlier so that we can optimize their volume status. We can optimize their other drugs, SGLT2s and diuretics and other diuretics and BP status. And third is the group where they have reduced GFR. So if anyone who has a creatinine maybe more than 1.5 or touching 2 or higher than that, I would be very happy if I am involved earlier so that I can take care of a hyponatremia from the perspective of decreasing GFR. And that also is a surrogate marker of declining GFR and worsening cardiorenal scenario. Yeah.
So that's so true, ma'am. So a collaborative approach is very important while managing hyponatremia. A nephrologist, an endocrinologist, and a cardiologist, they can just sit together and manage a patient more efficiently. So, that was a so that was truly a team sodium rescue mission. A heart, hormones, and kidneys perfectly aligned. So before we close, I would like to ask everyone about your sodium wisdom for the audience. One liner from each of you regarding your sodium wisdom for the audience, the physicians, and as well as the laymen. So, first of all, I would like to ask Kothari sir.
Yeah, so I would like to tell you that never lose your sight for the safety while correcting any sodium levels. Don't be in a hurry while correcting sodiums unless there are some neurological signs. That's a dictum. And definitely, rest of the things are the lab parameters, the lab patterns that we correct. But don't treat the numerics only. Treat the symptoms. Treat the clinical assessments which you make bedside during the clinical rounds at your hospital. That's it. Yeah.
Thank you, sir. So, coming to Manjiri ma'am.
Yeah, so I would say that first and foremost, check the volume status. If you think it is euvolumic, then you should definitely consider the hormonal causes. Like you should check your thyroids, the cortisol levels should be checked. Of course, the drugs should be reviewed into because SIADH is one of the most common causes of hyponatremia. The drug-related anticonvulsants, thiazide diuretics, antipsychotics, these are the major drugs which can cause hyponatremia. In elderly patients, you should go slow because most of the times they have chronic hyponatremia which are associated. And of course, if you know the precipitating cause, if it's an acute cause of hyponatremia, like say like there is a head injury, etc., then you can go fast and treat, you know, then you can correct it even within 24 hours. Otherwise, if it's a chronic hyponatremia, like Dr. Divya said, you should always go slow, not correct beyond 8 milliequivalents per 24 hours. So very, very slow. Volume status is first and foremost. Don't forget to check your hormones because hyponatremia is also an endocrine related disorder. Do not forget the endocrinologist and just focus on cardiology and nephrology because yes, hormones do play a part in hyponatremia. Yeah, so that is what I would like to say.
That's true, ma'am. Coming to Divya ma'am.
Yeah, so Saurabh, I would like to give a few tips about the treatment part. First of all, before hyponatremia sets in, I would like to tell all the colleagues here because almost everyone starts thiazides nowadays. So if you are starting thiazide, especially in an elderly person, at least get one reading of sodium and tell the patient that this can drop, this might change. We have had so many patients where thiazide was just started, indapamide, mitos, CTD, thiazide, whatever, and there was no sodium reading, and they directly end up with very, very low sodiums. So at least get one prior to starting and let the patient be aware of this. Second is in a elderly patient with frequent falls and subtle CNS signs, check sodium. Many a times it's a misdiagnosis. And third is, not all hyponatremias are to be treated with tolvaptan. Unfortunately, lots of our colleagues, they think that tolvat is a magic bullet, and you just give it little bit, give it 7.5 and give it for 4 days and sodium comes normal, and then forget about it. So do not give tolvat till you really know what the cause is, because if, first of all, if you have not treated the cause, like Manjari was listing out the drugs, if you have not looked at them, it will come again. Tolvat can harm your liver functions, so it's not completely safe. It can rise the sodium very quickly, and it's very very unsafe in someone with the hypovolemia. So it's not a completely safe thing. People, I have seen AKI due to tolvat because it was wrongly given in a patient with hypovolemia in a malignancy. So hyponatremia was because of enfalutumab, some fancy drug for CA prostate, and a patient was not SIAD. He was just not eating anything because of cancer. He was that beer potomania, tea toast kind of hyponatremia, and tolvat was given. Patient's creat started rising, and sodium normalized because creat started rising, and now he was having decreased GFR. So lots of messy situation to be in. Do not give tolvat to everyone before evaluation. That's my go-to hill I would die on.
Thank you very much, ma'am. So, Kothari sir, there is many heart failure patients. They ask, like, doctor, should I stop salt completely or not? Hyponatremic patients. So, what is your one-line advice to them on practical sodium restrictions that still keeps the life and food enjoyable? So, regarding the salt intake in hyponatremic patients, hypervolemic, hypovolemic, and euvolemic. So, what are your separate advices to all three categories of hyponatremia, sir?
So definitely hypervolemic is what I usually come across in my daily OPDs, as well as clinical practice during ICUs after discharge from the hospitals. So overall restriction of salt is definitely advised for all heart failure patients, whether they are reduced or preserved ejection fraction patients, and whether they have an hyponatremia or no. Definitely what we advise to a layman is just half teaspoon or less of sodium, including all whole day sodiums which you have, and restriction of fluids depending on the ejection fractions and the clinical assessments of what they presented with. 1 liter and less of sodium, 1 liter and less of water intake throughout the day, including all your intakes, is mandatory for all patients with heart failure. And that's it. We avoid reviewing of the sodium is a must. Follow-ups are must with
Yes.
serum sodium levels, and detecting the offending drugs like thiazides, carbamazepines, SSRIs is also one thing that on all follow-up visits is required.
And sir, what about the low sodium salt like Lona and these kind of salts? So, what is your advice regarding these low sodium salts, sir?
Yeah, definitely that's advisable for sodium. Like low sodium salts are advisable for all patients with Lona, like Lonas and all. For all patients, restriction of fluid with these things is definitely advisable.
Thank you, sir. So, Divya ma'am, there is a question for you. Like for patients with CKD, specifically diabetic kidney disease, with cardiorenal syndrome, heart failure, with reduced ejection fraction. So, in these patients, everything is to be restricted regarding the dietary advice. So, what is your key dietary counseling message that actually works in the real world?
Yeah. So, first of all, I would like to say that, especially in hyponatremic patients, like Dr. Kothari was saying, if it is hypervolemic hypernatremia, then definitely we reduce salt. But there are lots of other patients where we increase salt, specifically the SIAD ones. They are supposed to take 8 to
Yes.
10 grams of salt in a day. So, the amount of salt you're going to take has got nothing to do with your levels. It is about your cause, because of which your level has gone down. So that is one thing which patients should understand. Another very important dietary advice which I give to lots of my patients with hyponatremia is about protein intake. So it's very simple. In kidneys, if you eat enough protein, you will throw out adequate amount of free water, so your sodium levels are maintained. So in all hyponatremic patients across the board, almost for every cause, if they step up their protein intake, maybe to above 1 to 1.5 grams per kg per day, majority of our Indian patients are hardly eating zero point 0.6, zero point 0.8 gram, even if they are non-vegetarians.
Yes.
That 100% helps there to bring up their sodium levels, and that will not harm their heart and the volume status also. So that is one dietary advice. Coming now to CKD, which is or diabetic kidney disease, DKD. So my advice is pretty simple. Like I would follow, I would echo with Dr. Kothari that we should be restricting fluid to less than a liter if the patient really is edematous. We should be restricting salt. I would not give too much protein, especially animal based, to someone who has a progressive kidney disease. So I would like to restrict it not to more than zero point 0.8 gram per kg per day in a progressive CKD. If you don't have CKD, I would like to take into consideration what is your GFR. If your GFR is progressively declining, we really need to revisit all these dietary advices in frequent intervals. So what holds for me today might not hold true maybe 6 months later. So these values, these advices are quite dynamic, which patient need to realize. We give one advice, they take that, stick to it for months together. They come after a year and say, "Ki madam, aapne to ye bola tha." That doesn't help. It doesn't work like that. So drugs and dietary advices are very dynamic in these patients because the disease is progressive.
Thank you very much, ma'am. So, coming to Kothari sir. Sir, we have discussed sodium from every angle. So, what if a patient needs one practical tip that patients actually remember about salt and fluid? What that would be? Like one practical tip about salt as well as fluid that patients should remember. The heart failure patients who are with hypervolemic hyponatremia.
So usually, my personal tip on OPD basis is I usually tell my all heart failure patients to count on the sodiums through spoons maybe. Second is daily weight managements, like weight gains for all patients of heart failures is a must, because again water intakes and count on your water definitely. One of the things that patient usually ignore is the water intake that they daily have. Excessive water without counting, and on non-compliance of these drugs, especially the diuretics, make the re-hospitalizations in heart failures a common event in today's practice. So if medically we manage these patients, definitely the re-hospitalization rates for heart failures in hospitals will come down.
Thank you, sir. So, same question, ma'am. Like in your patients, like CKD with hypervolemic hyponatremia and patients on dialysis. So, one practical tip that you give to your patient regarding salt and fluid, so that they actually remember that and follow that.
So I want to tell all my patients that sodium is a fluid problem, water problem, and not salt problem. So they do their tests, and the moment they see sodium less than 130, they feel that they can eat salt. One thing is that you have low sodium in your body doesn't mean that you need to eat more salt. It is because you have more water and that sodium has got diluted. So you have enough sodium, but you have more water in according to that. So sodium and salt intake are not interlinked. Second, I want to tell my patients about lots of hidden sources of sodium in diet. Lots of things have more sodium, like for example cheese, mayonnaise, lots of salad dressings,
Pickles.
potted sauces, pickles. Yeah, pickles, so they are very salty. But lots of salad dressing and soups, they are little on sweeter side, but they still have a lot of sodium content in them because it's used as a preservative. So very important for my especially the cottage cheese, and those, they are not very salty to start with. You can have it on the pizza, but it has lots of frozen, anything processed, anything coming in a can will have lots of sodium because it is preservative. So I tell all my patients to read the label and take 400 mg as a cutoff. if your per serving content is going above 400 mg of sodium, it's not good for you. Even you, doesn't matter you have CKD, no CKD, you, even it for me and for Saurabh and for Dr. Meet Kothari, it's not good. So that is one thing I tell all my patients, to look for hidden sources of sodium in diet.
Thank you very much. That was very practical point, and I think that would help all the patients to just remember and follow. So that was a perfect discussion on sodium. So thank you to our three brilliant panelists and the 4D team for curating this cross-specialty dialogue. So when sodium falls, it's not just a number, it's a story of physiology, teamwork, and timing. And as our Mumbai experts showed us, sometimes the best correction begins with good communication. Thank you very much. Thank you, ma'am.
Thanks.
Thank you, sir.
Thank you. Thank you. Thank you.